What's kicking, everybody? We're going to do obstetrics and gynecology today, tailored to the emergency medicine shelf exam. Pelvic inflammatory disease, or PID, its greatest risk factor is untreated underlying chlamydial or gonorrheal infection. Being an adolescent, a smoker, having multiple partners, or IUD use are all risk factors. The symptoms include uterine and cervical motion tenderness, vaginal discharge, and fever. These patients are at risk for ectopic pregnancy and infertility down the line. Perihepatitis, which is Fitzhugh-Curtis syndrome, is a long-term complication where the liver capsule becomes inflamed and it ultimately leads to adhesions. The treatment is cefoxitin and doxycycline. You can also use Clinda and gentamicin as well. Tubo-ovarian abscesses are polymicrobial, and the treatment involves ampicillin, clindamycin, and gentamicin. If they are greater than 10 centimeters in size, they may require surgical drainage. Genital herpes is the most common cause of genital ulcers, and 50% of new infections are HSV2. The virus remains dormant and can reactivate, so primary infections are typically the worst, and the rash can last as long as 2 weeks. The secondary infection lasts 6 to 12 days, and asymptomatic subclinical viral shedding can occur even after the primary infection resolves. Diagnose with an HSV PCR. And the big one here is that pregnant women with active infections require C-section. So if they are actively having symptoms, you need to do a C-section. Strawberry cervix, think of trichomonas. The treatment is metronidazole. Bacterial vaginosis, I want you to think of clue cells, and it'll say it in the vignette as epithelial cells coated with bacteria. The treatment is topical azoles or oral metronidazole for 7 days. Bacterial vaginosis and trich occur at pHs greater than 4.5, while yeast infections occur where the pH is within normal range, like 3.8 to 4.5. Symptoms of candida or a yeast infection are itching, dyspareunia, and cottage cheese discharge. The treatment is oral fluconazole or topical azoles. And then Bartholin cyst or abscess is a polymicrobial infection, and the treatment is IND, incision and drainage. Ovarian cysts are often benign. They occur in all ages, but you'll see them more commonly in childbearing years, and you diagnose with an ultrasound. Ruptured cysts are usually treated conservatively. Now, any patient with an ovarian cyst with a sudden onset of adnexal pain, you want to think about a large cyst that's twisting. So you're going to be thinking that, if this big cyst is twisting, you can cause a large ovarian torsion, and you're going to diagnose that with ultrasound. I could easily see that being on the shelf exam. Now, catamenial pneumothorax is when there's a pneumothorax in association with periods caused by endometrial tissue that is actually in the thorax region. Primary dysmenorrhea is cramping pain in the lower abdomen, and it occurs just before or during menstruation. Most of the dysmenorrhea will respond to NSAIDs. Emergency contraception includes Plan B. It works for 4 days after intercourse, and then you also have Ella, which works up to 5 days and may be more effective. It requires a prescription, whereas Plan B does not. Endometriosis is when endometrial glands appear at extrauterine sites, so commonly you're going to see it at the ovaries, and it's associated with chronic pelvic pain and infertility. You diagnose by direct visualization through laparoscopy. Leiomyomas or fibroids are most common in women, and they're going to be the most common pelvic tumor overall. They contain estrogen-sensitive receptors, so they're going to often enlarge or rapidly enlarge during pregnancy, and they're going to shrink and regress during menopause. Symptoms include pelvic pain, abnormal vaginal bleeding, and you want to treat these with hormones. They can help, but the definitive treatment is hysterectomy. There are 3 gynecological cancers I want you to focus on for your emergency medicine exam, and so they all have very similar symptoms, but the big thing I want you to take away is any postmenopausal woman with vaginal bleeding needs endometrial biopsy and ultrasound to rule out endometrial cancer. Risk factors are diabetes, obesity, null parity, early menses. If an older female has malignant pleural effusions or ascites, I want you to consider thinking about an ovarian cancer or ovarian tumor. So you want to rule out ovarian cancer in these patients. Risk factors for ovarian cancer include family history, infertility, low parietal, and a high-fat diet. And then, of course, for cervical cancers, Early pap smears are very important in terms of screening and are needed in women with multiple sex partners, a history of STDs, and that's really going to help you evaluate for cervical cancer. Symptoms include postmenopausal bleeding and postcoital bleeding. All right, switching over to OB, because we're done with GYN now, there's going to be some basic physiological changes you just want to look out in pregnancy patients. They're going to have an increased heart rate, increased cardiac output, increased white blood cells, but their respiratory rate is not going to change. The second trimester, you may see blood pressures decrease, BU and creatinine ratio may decrease, and they may complain of delayed GI motility, gastric emptying problems. That can also occur. Hyperemesis gravidarum is defined as intractable nausea and vomiting with some degree of weight loss. The number one reason for hospital admission in the first trimester is hyperemesis gravidarum. The symptoms peak between 9 to 10 weeks and generally resolve by 16 to 18 weeks. The HCG can be detected 6 to 12 days after ovulation. It's going to double every 2 to 3 days for the first 10 weeks and then declines every 2 to 3 days for the next 10 weeks. And it's detectable for up to 2 to 3 weeks postpartum. Twin pregnancies, on average, have higher HCG levels than singletons, but you're still going to float in that normal range, that normal singleton range, even if you have twins. The earliest ultrasound finding on pregnancy is the presence of a gestational sac seen at 4 to 5 weeks by transvaginal approach, and then 6 weeks by transabdominal approach. The first true embryonic structure is the yolk sac, and you're going to see that around 5 weeks. The most common cause of first trimester spontaneous miscarriage is chromosomal abnormalities. In terms of miscarriages, we have a couple different types, all of which present with bleeding, pain, and cramping, and you can kind of follow along with the table here. So the cervical os is going to be closed, inevitable, the cervical os will be dilated. Then incomplete, we'll have the cervical os open, and then you're going to see some products of conception being passed. A complete cervical os will be closed, and the ultrasound will show an empty uterus. And then septic miscarriages, what you're going to see in a septic patient, fever, discharge, often due to polymicrobial bacteria. It's going to climb up into the uterus, ascend, and the treatment is IV antibiotics and D&C. That is very high yield. You're going to at least get one question on your exam with this. Ectopic pregnancies, when there's an implantation outside the uterus, the most common site is the fallopian tube, and 50% of women who get ectopic pregnancies, they don't have any underlying risk factors. However, the number one risk factor is a prior ectopic pregnancy, and oftentimes you're going to see these patients, they're going to need surgery. However, if the patient is hemodynamically stable with an HCG less than 5,000 and the ectopic size is less than 4 centimeters without cardiac activity, you can go ahead and give methotrexate. And then the most common cause of maternal death in the first trimester is ectopic pregnancy, so you really want to take this seriously. The most common cause of maternal death overall is a PE, a pulmonary embolism, and the risk of thromboembolism is highest in the postpartum period. RhoGAM is indicated in pregnant bleeding patients who are Rho negative. There's no need for RhoGAM if the mother and father are both Rho negative. The dose, it's less than 12 weeks, you want to give 50 micrograms, and then it's greater than 12 weeks, give 300. Gestational trophoblastic disease, or GTD, risk factors are extremes of maternal age, so like less than 20 years of age, greater than 35, and previous GTD. The serum HCG is much higher than normal intrauterine pregnancy levels and uterine size. Gestational age is associated with hyperemesis gravidarum, and malignant GTD, you're going to see things like invasive mole, choriocarcinoma. It's that classic snowstorm appearance on the ultrasound. The treatment is chemotherapy, and then when you switch over to the benign GTDs, what you'll see, and again, gestational trophoblastic disease, they're more benign. They're going to be non-cancerous tumors that develop in the uterus. They're usually you're going to have 2 sets of paternal chromosomes in the fertilized egg. You'll see a partial mole that will contain a fetus, and cardiac activity can be detected, while a complete mole, there'll be no embryo or normal placental tissue. The HCG should be monitored closely after treatment to assess for persistent disease, and you want to follow these levels until they reach 0. Some other high-yield obstetrics stuff you're going to see is all the placental abruption, previa, and accreta. So placenta abruption is the premature separation of a normally implanted placenta from the uterine wall. The risk factors include hypertension, smoking, multiparity, cocaine use, advanced maternal age, and they present with painful third trimester vaginal bleeding. It's diagnosed with ultrasound, but the best test is cardiotocography. The field of stress, even if mild, is going to be present in placental abruption. That's your big key here, and that's very high yield. You're going to probably have a question on this, honestly. And then, of course, in patients who have had placental abruptions, the future pregnancies are a very high risk for placental abruption in the future. Placenta previa, on the other hand, is an abnormal implantation of the placenta so that it covers the internal cervical os. The risk factors are multiparity, previous uterine surgery, advanced maternal age, and they present with painless third trimester vaginal bleeding. It's diagnosed with ultrasound, and you want to remember that the pelvic examination is contraindicated in these patients. Any patient with bleeding after 24 weeks should be evaluated with ultrasound to rule out placenta previa before a pelvic exam is done. And then placenta accreta is when the placenta implants with abnormal firmness into the uterine wall, and the first clinical manifestation you're going to see is just profound, life-threatening hemorrhage with attempted manual placental separation. The treatment is planned preterm cesarean section with a hysterectomy added onto it so that the placenta is left in situ, because if you attempt to remove it, if you try to remove the placenta, this patient's going to be at a huge risk of associated hemorrhage. So be very careful with those patients. And then umbilical cord prolapse is an emergency. It occurs at the same time as rupture of membranes, and it's diagnosed by palpating the umbilical cord on vaginal exam. You want to get the patient ready for an emergency section as quickly as you can. And then preeclampsia is defined as pregnancy beyond 20 weeks with hypertension, new onset hypertension, greater than 20 weeks. You're going to see proteinuria and edema. The symptoms include headache, vision changes, abdominal pain. The risk factors include extremes of maternal age again, so very young, very, very old, primogravid, diabetes, hypertension, obesity, and either very short, less than 2 years, or very long, greater than 10 years time in between successive pregnancies. The treatment is you're going to put them on bed rest, blood pressure control, but ultimately delivery is the only real treatment. So treatment of preeclampsia, deliver the baby. Patients will have an increased risk of preeclampsia in future pregnancies and a higher long-term risk for diabetes and coronary artery disease just overall. Preeclampsia may occur up to 6 weeks after delivery. And then you're going to want to also think of things like HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. If a preeclampsia patient has a seizure, she now has eclampsia. And the only real treatment for eclampsia, again, is deliver the baby. Magnesium treats these. You want to add magnesium as soon as you see the mother having seizures. You want to monitor for signs of hypermagnesium. So you're going to see things like decreased reflexes and respiratory depression. So you want to give mag, but you don't want to give too much mag because then there's downsides to having too much magnesium as well, okay? And then acute fatty liver pregnancy. It's rare. You're going to see it in the third trimester. It's going to have nausea, vomiting, epigastric pain, and liver dysfunction. Coagulation abnormalities can be present, unlike HELP. The lab abnormalities that are abnormal in acute fatty liver pregnancy are hypoglycemia and elevated ammonia levels. Rounding out the obstetrics portion of your high-yield emergency medicine shelf exam, we're going to cover medications that are contraindicated in pregnancy: sulfas, aspirin, fluoroquinolones, macrolides, tetracyclines, NSAIDs, ACE inhibitors, warfarin, most anticonvulsants. The greatest teratogenic risk factor during organogenesis, which is weeks 4 through 12 of pregnancy. The first step in ACLS for pregnant patients is displace the uterus and then start compressions. Trauma pregnant patients, you want to manually displace the uterus or turn her on her left side to relieve pressure from the IVC, which in turn will help avoid hypotension. Chest tubes need to be placed 1 to 2 intercostal spaces higher than where you would normally place them. Then you're going to also do 4 hours minimal of continuous fetal monitoring is mandatory for all patients greater than 23 weeks of pregnancy. And the most important factor in fetal survival is stabilizing the mother in these trauma situations. So if you need to do any sort of imaging, just do it. Don't withhold. Stabilize the mom so you can save the child. You want to consider ROGAM if there is an abdominal trauma. And then moving over to premature rupture of membranes, it's the rupture prior to the onset of labor. It's associated with frequency of digital pelvic exams. Use a sterile speculum if you can. And then Ferning is the most specific test. The normal vaginal pH in pregnancy is 3.5 to 6, and the pH of amniotic fluid is 7.1 to 7.3. Management is avoid multiple vaginal exams. If the cervix is favorable and premature rupture of membranes, deliver. If it's not, you want to ripen the cervix and induce labor. Breech babies have their butts as the presenting part, making vaginal delivery very difficult. So these babies need to be delivered via C-section. For shoulder dystocia, you want to perform the Mick-Roberts maneuver to widen the pelvis for delivery. And then amniotic fluid embolism. This patient, you're going to see in a question stem, they will have just delivered, and then the mom's going to become hypotensive, hypoxic, and probably go into respiratory failure. PE is a likely diagnosis, but if it's immediately after delivery, think amniotic fluid embolism. The treatment is supportive. Peripartum cardiomyopathy, it's just you're going to see your classic heart failure symptoms, which can present within their last month of pregnancy all the way to 5 months post-delivery. Risk factors include advanced maternal age, pregnancy with multiples, history of or preeclampsia, and maternal cocaine use. The treatment is just the same as all the other types of heart failure. You want to diurese, right? And then in future pregnancies, these patients are at high risk of maternal death, so oftentimes these mothers are not able to have any more children. Postpartum hemorrhage is the most common cause. You're going to see this is so high yield is uterine atony. It can be diagnosed on clinical exam with an enlarged soft uterus. The treatment includes fundal massage, oxytocin, and just overall supportive care. Retained products, most often the placenta, is the second most common cause of postpartum hemorrhage, and it should be considered in cases of delayed hemorrhage. And then uterine rupture can occur if attempting vaginal birth after C-section. Uterine inversion is caused by excessive traction on umbilical cord, and the treatment is manual reduction or emergent laparotomy. Endometritis presents with fever, abdominal pain, uterine tenderness, and malodorous loci. It's often due to a polymicrobial infection, and the number one risk factor is C-section. Another risk factor includes prolonged rupture of membranes and undergoing multiple vaginal examinations as well. That's another risk factor. The treatment is just antibiotics, usually clindamycin and gentamicin. And then last but not least, I just felt like I needed to include this. You may see this as well. Mastitis, you just look at the word, and that means mass, meaning breast, itis, meaning inflammation or infection. So the most common pathogen for mastitis is Staph aureus. The treatment is just to continue breastfeeding while taking antibiotics. You're going to do something like dicloxacillin or cephalexin. And that's it. That rounds out the high yield OB and GYN portion of the emergency medicine shelf exam. Let me know if this was helpful or if you have any questions. And thank you guys again so much for your time.